Yes, sir.
I think Sivathanu, you can go ahead.
Sir, good evening, sir.
Good evening.
Sir, nutrition in ICU. Medical nutritional therapy is not only aimed at preventing malnutrition and micronutrient deficiencies, but also aimed at achieving metabolic optimization, preserving gut integrity, and attenuating the stress-induced immune response. The ESPN categorized the stages of critical illness into 3 phases. First is the early acute phase, the first 2 days in the ICUs, and the acute late phase, which is 3 to 7 days in the ICU, and the third is recovery phase, which is after 7 days to months. So the initial early acute phase, there is an initial response to stress, which is characterized by increased metabolic rate, hyperglycemia, and insulin resistance. However, the energy expenditure in this stage is decreased. Second, the hypercatabolic phase, where it is characterized by the increase in metabolic rate, muscle protein breakdown, and all cause a rise in energy expenditure. And finally, the recovery phase, which is a focus on anabolic process. So, the key components of nutritional therapy is first, the early identification of nutritional risk, and second, the appropriate assessment of energy expenditure, and third, the timely initiation of the nutrition interventions. So first, the nutritional risk assessment. The ESPN suggests considering the patients at risk for malnutrition if they are expected to stay in the ICU for more than 48 hours on ventilator support and have severe infections or were under risk for more than 5 days before ICU admission. So the ESPN suggests both clinical assessments and some nutritional risk assessment tools. There are various nutritional risk assessment tools available, such as nutritional risk training to nutrition risk in critical ill score, modified nutrition risk in critically ill, subject global assessment, and a malnutrition screening tool. However, that nutritional nutritional risk in critically ill score and nutritional risk screening, both scoring systems pay special attention to nutrition status and disease severity. And second, to determine the energy requirements, here the indirect calorimetry is the gold standard method. It is non-invasive. It measures the volume of consumed oxygen and exhaled carbon dioxide through a ventilatory circuit, and thus estimates the patient resting metabolic rate and total energy expenditure. If that indirect calorimetry not available, then the ESPN recommends the using of exhaled carbon dioxide from the ventilator. And assuming that the respiratory quotient is normal and the energy expenditure can be calculated by substituting amount of oxygen consumed with the respiratory quotient value of 0.86. If both unavailable, then the ESPN recommends using a calorie intake formula based on weight. That is 20 to 25 kilocalorie per kilogram per day progressively during the acute phase, and increasing intake 25 to 30 kilocalorie per kilogram per day during the recovery. And but the weight-based formulas may not adequate for all patients, particularly those who are underweight or overweight. So the alternative approach is estimating the energy requirements involves the use of predictive equation. The most used equation is that revised Harris-Bennett equation, which is more reliable. And to accurately estimate the total calorie requirements, Harris-Bennett equation must include both activity level and stress factors. Therefore, the total daily calorie requirement is equal to resting energy expenditure into activity level into stress factor. And then the feedings, the macronutrients, and it includes both micronutrients. Macronutrients, first water is 30 ml per kg per day. Fluids provided by medications and enteral nutrients or parental nutrients contribute to this, and this should also be factored in total fluid requirements. And the electrolytes, the sodium and the chloride, 1 kilogram per day, potassium 0.8 to 1.2 millimole per kilogram per day, and calcium, magnesium 0.1 millimole per kilogram per day, and phosphate 0.2 to 0.5 millimole per kilogram per day. And it's carbohydrates. Carbohydrates accounts for major calorie requirements, 45 to 60%. The maximum recommended intake is 5 milligram per kilogram per minute. And proteins. The suggested dose range is 0.8 gram per kilogram per day in early phase, and is progressively increases to 1.3 gram per kilogram per day by day 4 of ICU. increases up to 2 gram per kilogram per day later in the critical illness. Later in the critical illness. And then lipids. For intravenous lipids, the recommendation is 1 gram per kilogram per day with a tolerance up to 1.5 gram per kilogram per day. And here the propofol is a source of fatty acids that contains 1.1 kilocalorie per ml and can provide a significant energy load. And micronutrients, prevention of maintenance dose of micronutrients is necessary. And immunonutrition, here it aims to provide specific nutrients that enhance immune function, reduce inflammatory responses, and support healing. Immunonutrients components include glutamate, fatty acids, arginine, antioxidants, and nucleotides. The enteral glutamate kilogram per day can be considered for burn and trauma patients in ICU for up to 5 days. And omega-3 fatty acids found in fish oils have documented anti-inflammatory properties that can modulate the production of inflammatory mediators. So the patient with conditions like respiratory distress syndrome, acute lung injury, and sepsis have shown improved outcomes in length of stay, ventilated day, mortality. So the ESPN recommends considering omega-3 fatty acid supplementation for patients receiving enteral nutrition or patients requiring parallel nutrition. However, high dose of omega-3 enriched enteral formulation should not be administered routinely. And arginate has also shown the potential benefits, but it has a risk of increased nitric acid production that can exacerbate hypertension in septic patient. And antioxidants should be added. And so the guidelines currently do not recommend the use of immunonutrition in critically ill population. And regular monitoring of nutrition status and immune function is crucial. And the modes of nutrition support. Routes of nutrition supports are enteral and parenteral. Enteral is further divided into oral and assisted enteral. First and oral. This is the most preferred method when gastrointestinal tract function is intact and the patient can safely swallow and digest food and liquids without complication. In indications, the patient should be fully conscious, alert, and has an intact swallowing reflex if all nutrition requirements can be met. It has advantages of maintenance normalcy and routine for the patient and is potentially reduced infections compared to invasive methods and is cost effective. It has disadvantages that not feasible if the patient is unconscious or unable to swallow, risk of aspiration, especially in patients with compromised swallowing reflex or altered level of consciousness, and they may not meet the fully nutritional requirements of critically ill patients. Second, that assisted enteral. Here, the nutrition is delivered via a feeding tube directly into the GAT is a preferred method for patients unable to consume food orally or difficulty in swallowing, but with intact gut function. Tubes can be inserted nasally, orally, or via abdominal wall. The ESPN recommends establishing a gastrotomy for patients admitted to require enteral feeding for more than 3 to 4 weeks. And it has an advantages. It is cost effective, easier to administer, maintains gut integrity and function, reduces the risk of infections compared with parenteral feeding, and can be easily continued as the patient transitions to oral intake. And it has its own disadvantage that risk of aspiration in critically ill patients, not suitable for patients with severe gastrointestinal disease. And it is a slower rate of nutrient absorption than parenteral feeding. And tube displacement, clogging, or other complications such as gastrointestinal necrosis may occur. And parenteral nutrition. Parenteral nutrition involves that direct infusion of artificial nutrient bloodstream via vein. It is indicated when oral and enteral feeding is not feasible or contraindicated. It is 2 modalities, one the peripheral parenteral nutrition and central parenteral nutrition. And it has an advantages that is provide essential nutrients directly into the blood and useful for patients with severe gastrointestinal tract disease. It's when enteral feeding is not feasible or sufficient. Disadvantage is expensive and complex to administer and high risk of infection, sepsis, and metabolic complication may lead to hepatic dysfunction and electrolyte disturbances with the long-term use and a limited to maintain gut integrity. And how to decide the feed type? Here, when the patient is admitted in ICU, to perform the clinical assessment and nutrition risk screening by the scores, and first to assess whether the patient is in low risk for malnutrition or high risk for malnutrition. If the patient is in low risk for malnutrition, whether the patient can take oral feed or not. If he can take oral feed, then oral route is preferred over enteral or parenteral. If it is in oral, if it's not tolerated, then consider progressive yearly enteral nutrition. That is within 48 hours, if no contraindication. If it is in high risk nutrition, then can start the enteral feeding preferred over the parenteral feeding. And it's a complication. It's a common complication. Complication also need to notice about is a common complication. First, the overfeeding and underfeeding. Overfeeding is more prevalent in those receiving parenteral nutrition. It is recommended to gradually increase the protein intake to 1.3 gram per kilogram per day to avoid overfeeding. Underfeeding is defined as providing less than 70% of the intended amount. Commonly occurs during the enteral nutrition due to various factors such as feeding intolerance, airway management difficulties, or some interruption in feeding caused by investigations or procedures or elective operations. Second, hyperglycemia. It is also more in particularly among those receiving parenteral nutrition. And ESPN guidelines recommends initiating initial therapy when the blood glucose exceeds 10 millimole per liter. And refeeding syndrome. It is severe and potentially fatal metabolic complication that can occur in patients in the ICU when the nutrition is reached after a period of malnutrition or fasting. The pathophysiology involves a rapid shift from a catabolic state to anabolic state, leading to surge in insulin secretion in response to carbohydrate intake. The increase in insulin level drives the uptake of glucose, potassium, phosphate into the cells, potentially causing electrolyte imbalance and hypophosphatemia, which is considered as a hallmark feature, and hyperkalemia and hypermagnesemia. These disturbances usually occur within the 72 hours of medical nutritional therapy and may result in various complications such as cardiac arrhythmias, respiratory failures, muscle weakness, and some neurological symptoms. So close monitoring and gradual reintroduction of nutrition are crucial for preventing and managing refeeding syndromes in these patients. So the recommended guidelines is to start feeds at a rate of 10 kilocalorie per each kilogram per day or lower, and gradually 4 days to meet a nutrition needs. And the electrolytes should be measured at least 2 to 3 times daily, and sufficient daily micronutrient intake should also be ensured. And additionally, thiamine supplementation 200 to 300 mg per day is recommended for the first 10 days. And some complication which is specific to parenteral nutrition is first a complication related to catheter insertion complication and complications, including hyperglycemia, hyperglycemia, electrolyte imbalance, and Wernicke's encephalopathy, and liver dysfunction and refeeding syndrome. So there's a close monitoring of metabolic status and considering a reduction in the energy doses if the patient experiences any one of the following. That is a decrease in serum phosphate level from the baseline, or serum glucose level more than 10 millimole per liter despite adequate insulin therapy, or acute severe hypertriglyceridemia more than 4.5 millimole per liter. And parenteral nutrition associated cholestasis is a complication. And a complication specific to enteral nutrition is enteral feeding intolerance. Enteral feeding intolerance may present as gastric residual volume of more than 500 ml 6 hourly. Vomiting, abdominal pain, distension is usually the feature. And early full initiation of enteral nutrition associated with higher incidence of enteral feeding intolerance. And the strategies for managing enteral feeding intolerance is exclude a pathological cause, example sepsis or intra-abdominal collection or obstruction, and temporarily reducing the enteral feed if the gastric residual volume is 200 to 500 ml 6 hourly, or nutrition if a gastric residual volume is more than 500 ml. And administering prokinetics, intravenous first line or metoclopramide, and considering post-pyloric feeding if no bowel distension. And diarrhea and emission most common complication of the enteral nutrition, and is content and composition of feeds in carbohydrates, lipids. Additional contributing factors include the use of hyperosmotic drugs, botulism antibiotics, and some industrial infections. And management based on the pace of illness. Start daily progressive enteral nutrition within the 48 hours, and avoid fully daily nutrition, and avoid parenteral nutrition.
Your audio is breaking, Sivathanu. So, I think he has lost connectivity. Yeah?
It's more than 7 in nutrition. Comments parenteral nutrition if enteral nutrition contraindicated or insufficient, And here the energy target is isocaloric 80 to 100% estimated of measured, and protein target at least 1.3 gram per kilogram per day. And post ICU discharge, the calories increase target to 125% of the estimated requirement. And the protein target increased to 1.5 to 2 gram per kilogram per day. And hospital discharge, here the calories increased to 150% of the predictive equations or indirect calorimetry, and the protein targets increased to 2 to 2.5 gram per kilogram per day. And consider extended tube feeding for
some problem with this connectivity. It is getting disconnected.
Yes, sir.
Right. Let him